Do you want chairs? Bring your chairs round.
You can have a wooden chair. I'd never sit on a wooden chair in my life.
I'll make it on time.
Never.
There's a question here that's been wanting to be asked for like maybe half an hour.
No pressure then. I wondered if there's been any studies done in terms of whether diet can play a part. I mean, obviously I would suspect it can, but whether it can play a part in control, you know, in terms of dietitians or nutritionalists or whatever else, whichever specialist area needs to be involved.
Who wants it?
I think that, you know, there's a pragmatism about the family that's in front of you in a clinic, and you know, I work in London, and some of the families have difficulty managing the bus fare to come to the appointment, and to say to them that diet's really important because we think it is in terms of your child's general health, but also in terms of managing their bowel function. And it would be really good if they could have lots of fruit and vegetables, knowing that actually they're not going to eat that. So that's why I think my reliance on laxative medication to regulate bowel function, particularly in a preschool child, is because most parents that I've spoken to find it difficult to get their child to have that kind of diet. But in those families that can achieve it, I've seen families who can regulate their child's bowel function entirely by giving them an extremely healthy diet, plenty of fluids, lots of fruit, 5 vegetables a day, that kind of thing. But I think you just have to be realistic in terms of what the family can achieve and what your advice is if your goal is to get that child to be able to still regulate. But I think it is important. I guess I'm a little bit surprised how infrequently I actually refer families to formal dietetics. And I probably would only reach for that particular thing if I was concerned that the child wasn't thriving and it was an issue about their calorie supplementation or their nutrient intake that was actually having a physical effect on them thriving.
So I think fluid, dead important. Healthy diet generally for well-being, definitely, within the parameters that Joe's described. Some people just can't afford it. We talked a bit about fibre, and that's to me a known unknown. I'd like to learn a little bit more. It is untrue to say that kids with low fibre diet end up with constipation because of that, because otherwise you'd expect siblings to have the same problem, but they don't. It is also true to say, however, that increasing the fibre does do something beneficial for constipation. So there's that way around, if you see what I mean. Nutritionist, you said. Where I live, people, I think to some degree, people get influenced to go to see a nutritionist based more on their postcode. Perhaps there's some postcodes where we're more likely to have nutritionists try and access people that are not. And in truth, I'm going to say it's something I just don't know about. I think cow's milk protein allergy can be relevant in constipation. I think allergies are a funny thing, and this chair's set up for somebody that knows the answers to questions that we don't know. So a gastroenterologist might have a more valid view than me about allergies.
This is one thing that I've dealt with when I've been in America, that they have a term called mechanical emptying and medical emptying in regard to having a clean bowel or whatever. And the first time I asked the question to Mark Levitt was, do you take into account the psychological effects of the constant enema or washouts? They sort of like were a bit taken back a bit because I'm not sure whether they've been asked it before. What is your experiences with you, Pete, your expertise when it comes to getting the child clean if it is a constant enema regime and the invasive aspects of that.
I have to say I'm not a very super analytical person, which probably, I don't know whether that helps. I know that my patients, whatever they're doing one week, I can bet bottom dollar they won't do the next week. And so regarding diet and or washouts, I think, do you know you can have compliance for so long, but one week you might eat bananas every day and you might eat 10 of them. The next week, you know, you won't eat what you were doing last week. So I think my approach with my families is hopefully very honest, because I know what we instill last month won't necessarily be working next month. There is no way you can do transanal irrigation on somebody who's just rigid and clamping their legs down. And so there may be a phase where it's worked beautifully. So some of my 3-year-olds have been doing irrigations wonderfully for, you know, 12, 18 months, and actually they know their bowels so well that they ask if they're bunged up a little bit, that they know they want another washout doing. But then there'll be another phase where you can't go near them. And so I think it is just a progression of tweaking. I always say to my families, I think we should tweak, you know, do your diet, whatever you do as a family and your other children, and we just tweak around whatever is going on. You know, there's a lot of tweaking we can do, and try not to overanalyse, because, you know, my own bowel regime might be completely different from my lovely colleague here. We don't discuss that over lunch, I could say, but perhaps we should. So, you know, we're all so different, and siblings within the family are so different. Is that helpful? Does that answer?
I'm more looking at it from the perspective of the invasive, intrusive procedures on the child, and whether that's taken into account more than the getting the clean out.
Yeah, definitely. So, I mean, I have to have my children on side, and often when I'm teaching a peristine or Q4 type washout, we have our play session first. We use the equipment. You can take it home, you know, you can practice. And I think for children who are perhaps the 7, 8, 9, the first thing for them is to try inserting the cone or the catheter themselves before you attach it to the rest of the kit. So let them get used to placing it, because if you're doing it yourself, it will be much more comfortable, I believe, than somebody else trying to do it for you, and getting used to it, and then come back to me when, you know, you said actually that might work, or put it on the back burner, but remember that Alison said, you know, at some point when I want to go on a school trip, that might be the actual useful thing that's going to work for me. And so come and give me a call and we can go through it all again. Do you know, it's kind of like planting seeds a little bit and saying this probably won't work now, or there might be a time where it's not going to work, but let's revisit it. You know, I'm here for you to do that with, and we can look at different systems if something's not working. But yeah, the rigid child with crossed legs, you know, that has to be acknowledged. There's nothing, you know, we have to change our tack until the time's right, and you can come back again and say, maybe we should try something else. Is that helpful?
Can I just ask a quick question? What would be a good age from a girl, an adolescent girl of 11, to sort of look into her reproductive system from a point of view whether she's got 1 uterus, 2 uteruses? If you could answer that, would be great.
It would be great if I could answer that, yeah. I suppose something I've seen is that there seems very little point in labouring the issue until she wants to talk about it.
Okay.
We have the discussion very often in a kind of a typically British beating about the bush sort of way about the plumbing you've got down there. You know, I'm embarrassed even to admit that that's the way that we talk about it, but there are some families who just talk about this in very matter-of-fact way from the get-go, and there are others that you see who are dying a million deaths at that age. Certainly we try and have the conversation before the onset of periods. So from the start of breast development, you've got about 18 months.
Okay.
before you start to get periods. And what you wouldn't want is to have a potentially obstructed vagina and a duplicated system that might then cause pain. Now, quite often the way it happens is that they come to the clinic to say, I've been having periods, but I've been having intermittent pain as well, and then you do a scan, and that's when you discover the obstructed system.
Okay, would that be an ultrasound or an MRI scan?
So we'd always start with an ultrasound. It's non-invasive, it's simple, and often gives you the answer. You do sometimes get variation in the way ultrasound's done. So ultrasound is done in a children's hospital or the children's department of a general hospital. It's done by a radiologist who's used to doing ultrasounds of the bladder in children, is often very good. Ultrasounds that are done in units in a general X-ray department that are done by technicians without understanding the question you're trying to ask are often not very well done.
Question there. So it's not so much a question, it's a sort of follow-up to your query. I'm an IA adult and I had both double vagina and duplex uterus, which wasn't diagnosed till I was 23, despite the fact I'd been going to my GP for years saying there was something wrong, I couldn't use tampons, etc. But just to reassure you, I would think that has totally changed now. And if I went to a GP today as a 14-year-old, I'd like to think I was taken seriously.
It would be nice to think that, but I can think of very recent anecdotes I can think of somebody who turned up with not only an obstructed uterus, but an obstructed kidney because of the obstructed uterus. It's rare though, it is rare. I think generally you're right, but it's the recognition of a red flag symptom, because duplication is important, because you can have normal periods from the non-obstructed side, but you can still get pain, or you can get it pushing on a ureter from the kidney. I'd like to think that he would get taken seriously.
My GP is at the moment, I'm pretty much guaranteed that they I was laughed at, basically. Time to go away.
I think it's important to say something about GPs in the context of a rare abnormality, because an average GP in their career will probably only have 2 or 3 children in their entire career with this condition. So I think it's a partnership between the experts in the ivory tower hospitals and the GP. We are the experts in this condition, and we should be setting families up to be aware about the implications of girls through puberty and managing that. And the general practitioner should be able to manage all of the other things they've managed for any of their other patients without this condition, and be a partner in making sure that the treatments that you set in place are something that they will continue. But we shouldn't be expecting GPs to be making what are difficult diagnoses in the context of this. Yes, they should recognise if a patient's got symptoms and know what to do about it, but I would actually put that responsibility back on us to say that it's up to us as the professionals managing the condition to make sure that we've anticipated that step in a child's development and put everything in place. It doesn't absolve a GP from recognising if a patient's got a problem and knowing where to go with that, but they're never going to be able to make that kind of a high-powered diagnosis like that. So I appreciate it. But I think the thing that probably has changed is that we would hope to be setting families up to be able to manage that situation better and that transition better. I'll just take a question here. Yes.
I had a question about how do you know if your child is emptying sufficiently? So my son is 14 months, he's not on any laxatives post-surgery. He poos quite frequently, but I don't know if that is enough, whether he should be on something, whether he shouldn't. So it's it might not be that easy to answer, but...
I don't want to answer that as a surgeon, because we're not the guys who are speaking to families day in, day out. I'm going to move that question to you.
It's a tricky one. I think, going by how he's eating, how he is in his behaviour, and you kind of get to know his tummy quite well, I think. His shape whether he has protrusions, whether he has a nice flat tummy, or that kind of funny sticky out on one side bit. Does he pass wind in between? So often I would think if you were telling me that he was still having 3 poos a day and everything, he's eating well, he's, you know, doing all the things you'd expect him to be doing, you know, there's always poo coming round. Your next meal is always there. And so there's never a sort of a time, I don't think, where it's, you know, your bowel's not empty and then your next meal comes through. It's always progressing round. And so I think taking into account all those other things, and as long as he's not straining to have his bowels open and those poos are coming through really nicely, and, you know, it's a poo that he can push out nicely and he's not having to do several different manoeuvres to get his poo out, and that there's no concern about any sort of narrowing anywhere along his tract, then I think 3 poos a day, that sounds really fine. And if they're poos in the daytime and not, you know, he's not pooing all over the night time, then we've got some good idea that he's in a good position, I would say.
I do definitely agree with that. For me, first sign of there being problems is distension, just a little bit of distension. You might know that because the nappy or the clothes don't fit properly, you know, and wee leaks a little bit if it's a nappy. Second thing that we see a bit in clinic is where there's just non-specific symptoms of, you know, just a little bit, you know, maybe a little bit of smearing or something like that, just something that maybe once a week that haven't been seen, hasn't been picked up before. And if one of those 2 things happen, then what we try and do is do something objective to measure the transit. Now, we use markers quite a lot in Leeds, probably elsewhere, just because it's good to get a handle on it. But that requires a little bit of organisation to get the markers out. So when you've got a family that are, you know, smart and focused, it makes it a lot easier. And what we generally do is we get them to give the child once a week, and only once a week, some sweet corn. So here's the numbers, and I'm going to tell you what I know about the numbers. If you've got a child that's asymptomatic, like doesn't have those problems, don't do the test. Otherwise, we're perhaps over medicalising things. If you've got a child that's getting symptoms, then there's a question to answer. So the question is, do they have a build-up of stool and overflow starting, or whether or not they are over-treated? So if they've got overflow or over-treatment. Okay? So what we usually do is say, if you see the sweet corn within 24 hours, it's probably going through too fast, so you're probably on a bit too much medication. If you're on medication, you know you're not. Your child isn't. If it's 48 hours or more, or more typically you don't actually see it because it's just being digested, then it's probably that you've got a bit of impaction developing. So where do I get the numbers from? There was some work that I was involved in where we measured this using some fancy test where you drank fluid and then you measured transit. And it felt like somewhere between 20 and 48 hours was right. Now look, that's not massively sophisticated high-powered medicine, but it's cheap and it's free, and you can just get it off the shelf. And if it works, then great. If it doesn't, please tell me. Okay, just take a question at the back.
Thank you. I wanted to ask if you had any thoughts or experience on the muscles of the bowel having problems and muscles elsewhere in the body. My daughter didn't walk until she was 17 and a half months, and she's 4 and can just jump. It was first of all nursery that identified that gross motor development, there was an issue. And when I looked at studies, I found 2 studies that said gross motor development was associated with or having a
microphone. I think that, as we mentioned earlier, that the attainment of continence is about nerves and muscles, and it's about the local nerves that come from the tail of the spine, which are sometimes abnormal, but the attainment of continence is about the control that your brain creates in controlling the lower nerves and your muscles as well. And if that is not working effectively, then it will have an impact. I'm trying to think of any patients of mine with erectile malformations who have a known, or should I say an unknown developmental problem in terms of their gross motor development. Honestly, I can't think of one. If I put on another hat in my colorectal practice, we've got children who've got really bad constipation, in whom there's a definite association, particularly in girls, with muscular development and being over-flexible or having poor tone in their muscles and joints. And that's very well recognised. But I'm not sure in my erectile malformation group that I'm aware of that. I'll pass on to colleagues to see.
Our daughter has that. She's just been diagnosed with hypermobility.
Yeah.
So, accepting that, you know, we don't know the fine detail of any particular family, I'm the same as Joe, if it helps. I've not heard of an association with gross motor problems other than because the spinal cord's not right, for example, you know, and affecting the legs. I've not heard that, but you can have two things in parallel, in conjunction. I hope that helps.
Thank you. We're going to make that the last question, everyone, if that's okay.
Just coming back to the things you're saying about the sweet corn trick.
Yeah.
I find that my son's digestive system is like a little black box. There's so many variables to what goes in. You might do the same thing one week to another and get totally different results. It can be really frustrating.
Yeah.
Because you don't know, you're doing so much trial and error, but you don't know what's going to work and what's not working.
Yeah.
Looking at things like that, and again, I know in America on the bowel management program, they do scans every day to try and see exactly what's going on inside.
Yeah.
Is there anything else like that that can be quite useful to try to figure out kind of what's actually going on?
Yeah. Okay, so the thing that they did in the States for the bowel management program was they brought people in, they gave a contrast enema. Water soluble contrast was a way of effectively manually disimpacting someone, because the contrast agent empties you out. And then they did x-rays every day, and they used the x-rays to assess efficacy of the washouts. Now, my strong understanding is that it's very hard to correlate plain x-ray with how full your bowel is. You can get an idea, but it's hard to be accurate. If you were setting this up as a metric to design a study, you would not use plain films. What some people have done, most notably in France, with two centres, they've used ultrasounds, where they've used ultrasounds to guide the efficacy of washouts. So you could apply that to transanal irrigation, for example, to look at that. But in Nottingham, where Alun works, and Alun may comment on this, as a team, Shalinda Singh did studies where he used ultrasounds to look at the thickness of the rectum, the fatness of the rectum. But actually, my answer to your question would be, is your child's tummy is like a black box. That's exactly it. In order to be logical about how to fix a symptom, it's worth thinking about getting under the bonnet. Then you can be precise about what you think you're trying to do, and then you're more likely to achieve it. So this business about sweet corn, I'm not, as far as I'm aware, a jolly green giant. But the thing is that find your own way of being logical about estimating the transit, because you're going to be more effective with your treatment.
Just to pick up on the ultrasound, I mean, it is something that we do use in the clinic because it's easy to do manually. When Shalinda, my colleague, my general surgical colleague, looked at this originally, he he measured some numbers that might be useful. The trouble is, your rectums are different size according to when you last had a poo, when you last had a washout, what your underlying condition is. A lot of the neuropathic children and adults will have bigger rectums. It's hard to validate which bit of the rectum you're measuring, but if you're using it as a serial tool, so you're doing a scan 1 week and a month later you're doing the scan again, and a month later you're doing the scan again, and you're looking at how well you're doing, it's okay. It's not difficult to do. I do it.
Okay, I'm afraid we're going to have to stop there. As much as I'd like to leave this carrying on all afternoon, but so I'd like to say a massive thank you to all of you for coming along and being with us today. If you're staying for the rest of it, I don't know what your plans are, but we're going to have a tea break now, everybody. So you'll see on your we're a bit 10 minutes late, but still have a 15-minute break. So we're back at 25 past. That's good. Thanks very much.